we can start in time.
Yeah, okay.
What do you think? Yeah.
Yeah.
So, very good evening, everyone. I'm Dr. Lucas Pereira, and together with Dr. Khalil, we will be facilitating today's special event, which is being organized by the regional chapter Rio Grande do Sul of the Brazilian Society of Surgical Oncology. We are very pleased to welcome today our fellow members from society, students, and professional colleagues. Today, we are honored and grateful for having a very special guest, Dr. Tsang, Honorary Clinical Associate Professor at the University of Hong Kong and Constant Surgeon at the Department of Surgery at Queen Mary Hospital, where I was kindly welcomed by Dr. Tsang and Dr. Shang a few years ago. Dr. Tsang very kindly accepted my invitation to talk to us today and share his experience on Hong Kong and how Hong Kong is winning the fight against COVID-19, which is an unprecedented event impacting the lives of the whole planet. Just before inviting Dr. Tsang to start his presentation, a few admin reminders. I would like to ask you all to keep your Zoom connection in mute to avoid background noise during the presentation. I can control a little bit, but you'll have to do that, please. Just after the presentation, we will facilitate a section of Q&A, questions and answers, via the chat feature in Zoom. You will be able to submit your questions even in Portuguese, and Dr. Khalil, Dr. Jorge Lira, and I will select and translate into English so that Dr. Tsang can kindly answer us as much as possible, after which the event will come to the end. This presentation will be available at sbco.org.br. Without further delay, it is our pleasure to invite Dr. Tsang to begin. Very good evening. I guess it is Friday morning for you, Dr. Tsang.
Yes, it is. Yes.
Thank you very much for accepting our invitation. Yeah,
You're welcome. It's my honor.
You can start. Yeah.
Okay. Please. Right. Good evening, ladies and gentlemen. I'm Simon Tsang from the Department of Surgery at the University of Hong Kong, and I'm very honored to share my humble experience regarding what we're seeing in Hong Kong as a surgeon during the COVID-19 pandemic. Hong Kong is part of China. And I was actually, a few years ago when I was visiting Brazil, during the IHPBA in Sao Paulo, at the airport, as I was about to leave this lovely country, I saw this poster. It's an advertisement, a scale of the two countries, actually the maps of the two countries superimposed to scale with each other. And in fact, Brazil is probably just as big as China, just as diverse, with a very large population. And to be honest, it's they share a lot of similarities, although they are on opposite sides of our planet. But Hong Kong is a relatively small place. It's in the southern part of China, on the coast, as you can see here. Its area is only 2,755 square kilometers, and the population is around 7.5 million. Whereas China as a whole has 1.4 billion people. But Hong Kong is a small place, but it has a relatively high population density of over 6,700 persons per square kilometer of land in Hong Kong. And so it is a very densely packed city. And as you can see here on the map is Wuhan in W. Wuhan is the place where COVID-19 all started late in 2019. And that's only just under 1,000 kilometers from Hong Kong. And so we're actually pretty close to each other. And there's a lot of travel between the two places as well, as I'm going to show you. But Hong Kong is a small place, but it's a very happening place. We had a very painful experience 17 years ago when SARS came along in southern China. China was very badly affected, but we still do not know how badly affected mainland China was. But what we saw in Hong Kong was a bloodbath. It was terrible. There were over 1,500 cases in Hong Kong. People were falling ill. There were massive community outbreaks in apartment blocks, inside hospitals. Doctors, nurses, other healthcare workers were sick. It was terrible. It was 3 months between March and June 2003 was like hell for us. And as you can see here on this photo, taken in around May 2003, on the cover of Newsweek, it says, SARS, can it be stopped? The new age of epidemics. SARS stopped in the summer of 2003. But SARS was different because that was, although it was a coronavirus, it's different from COVID-19. COVID-19 is much smarter. It didn't seem to kill people so quickly compared to SARS. Because what happened was, there were 1,750 cases of SARS in Hong Kong over those 3 months. And that resulted in 286 deaths. And that gave a staggering death rate of over 10%. And that included healthcare workers, doctors, nurses, nursing auxiliaries, other people as well, all walks of life, young and old, pregnant women. Babies lost their mothers, all within 3 months. It killed very quickly. And there were large-scale community and hospital outbreaks because Hong Kong was truly unprepared for it. It was a very advanced city in Asia, probably the most technologically advanced, economically advanced, very free, but its hospitals were all geared up for problems of the first world. And that was treatment of cardiovascular diseases, treatment for cancer, tertiary care, and very little emphasis was based on infectious diseases and ICU care at the time. And so people were struck at the time completely unguarded. And it was extremely painful to society. And people realized how important it was, but that was too late because they actually had to be, the healthcare workers who died were crowned as heroes, but that was too late. There was too much, well, that was just too late. Too little was done too late. And so over the past 17 years, healthcare system in Hong Kong changed a lot. The government started pouring money into it. A lot of emphasis was made on training doctors in infectious diseases. A lot of research was taken on SARS and other infectious diseases. And people were more aware that if you're sick and if you have a respiratory illness, you should wear a face mask. That was what kids were grown up with since 2003. Hospitals started stockpiling on personal protective equipment. And people were more aware of what things were. And it all seemed very peaceful for many, many, many years. And then I got this email. I literally dug this out of my inbox, dated on the 31st of December this year. And it says that it told us to be extra vigilant against pneumonia cases in mainland China. They didn't say what it was, but the hospital authority, that's the governing body for all government hospitals in Hong Kong, said that the causative pathogen of the pneumonia cases was yet to be identified. And as a precautionary measure, we should pay special attention to this, to the clinical information and the travel history to Wuhan within 14 days before the onset of symptoms. And so the government activated the serious response level 4 on the 4th of January and made all doctors to ask their patients whether they've been to mainland China, whether they've been to Wuhan, whether they've had any contact with anybody who had been to mainland China. And the hospital infection control measures were all ramped up. And immediately, surgical masks were made mandatory inside the hospital. You can't enter any hospital in Hong Kong without wearing a surgical mask. Everybody was kept on tenterhooks, and there was a as the epidemic raged on in mainland China, it was on the 23rd of January this year when two men fell ill. They had recently arrived on the high-speed railway from mainland China, from Wuhan. And that turned out to be a very busy travel period in Hong Kong, because that was just before the Chinese New Year, the Chunyun period, when that's crowned as the biggest human migration on this planet, because that's just before Chinese New Year, when all the workers in China were traveling back to their hometowns. And it turned out that there were two imported cases from mainland. And soon after that, there were local clusters as well. In temples, people came worshipping and infected each other. In restaurants as well. There were family gatherings during Chinese New Year. There were no social distancing measures at the time. And there were clusters of infections, people falling ill within families and within friends. And initially, Hong Kong society did little apart from closing schools. The government ordered all schools to close since the Chinese New Year in late January. But then soon started a major public awareness campaign, and the government workers were asked to work from home or perform flexible working hours when only half the workers would turn up to work every day, so that to free up office space and make sure that there's enough social distancing. And other employers were voluntarily asked to allow flexible working practices for their staff as well. And people, learning from SARS, bought their own masks. The government did not provide them. They bought their own surgical masks. And surgical masks were worn by over 90% of people on the street. And there was also made compulsory were temperature checks and face masks indoors inside public buildings. And those who had coronavirus were all admitted to hospital. And those who were in close contact with them were compulsorily held in quarantine camps. They were not, if you've been in contact with somebody with coronavirus, you are ordered to enter a quarantine, and you'll be detained for at least 14 days. And swabs would be taken, and you only be allowed to out if you're confirmed to be negative after 14 days. And that was non-negotiable. Unlike some of the governments in Europe, unlike the United Kingdom, where self-isolation was the word, in Hong Kong, it was kept in quarantine, and that was an order, it's by law. The police are allowed to grab you. And the government response was there were daily briefings by doctors on TV every day. These two ladies are on TV for most days over the past 3 months. And because Hong Kong has a general dislike for politicians, and so politicians did not come out to talk, they were left to technocrats and doctors and administrative people, whom the people of Hong Kong had a much higher regard for. There were ramped up hygiene measures, such as these photocatalytic disinfections of public washrooms. This is, I think, a robot that is in trial in Hong Kong. And this is a map, this is picture, shows rush hour in Hong Kong. There was no lockdown. But if you zoom into any of these pedestrians, every one of them, apart from one, was wearing a surgical mask, I found out. And so that was a spontaneous measure of the population. How good were surgical masks? The WHO initially said that they were not very helpful. Many countries in Europe said that they were not helpful. Donald Trump still refuses to wear one. But studies in Hong Kong and abroad have shown that on average, if you're wearing a surgical mask, if you're well, there is a reduction in exposure to aerosolized virus, because the viruses can penetrate surgical masks per se, but then the viruses are usually shed on droplets, and the surgical masks prevent droplet infections. And so if you wear a surgical mask early and correctly, you may reduce influenza transmission as well. And consistent mask use in the community was a protective factor against SARS in 2003. And if you're sick and if you're wearing a surgical mask, you may reduce shedding of aerosols. And if you hold a cough plate 20 centimeters from a person with influenza who has a mask, then you do not actually get any virus on the plate. And it seemed to be helpful. And what was seen in Hong Kong was the Hong Kong healthcare system was actually prepared to bear two major outbreaks. One was COVID-19 and the other one was seasonal influenza, because it's winter in Hong Kong in January. But because people were wearing masks because they were so afraid of COVID-19, the influenza season was negligible in Hong Kong. The influenza season in Hong Kong ended nearly 2 months before it's meant to end, usually. And so we actually prevented 2 diseases at the end of the day. This is the epidemic curve. Starting in late January, there were only a few and sporadic imported cases in Hong Kong, and then we started seeing clusters of local infections. But then everything seemed to be okay. There were days when there were 0 infections in early March. And then what happened there? That was when Europe and North America started having big outbreaks. People who are residents in Hong Kong, but who had traveled or worked or were working or studying in Europe and North America decided to return to the relative safety of Hong Kong. There was a mass exodus of people entering Hong Kong from Europe and North America, because the Hong Kong government announced some travel restrictions saying that after a few days in late March, they're going to start having quarantine of everybody returning to Hong Kong who are residents, and they would bar non-residents from entry into Hong Kong. But unfortunately, there was a gap of the periods when there were no restrictions, and that's when these guys came back and brought back their viruses and brought back their infections from Europe and North America. In fact, for the first month and a half of the outbreak, only around 20 cases of COVID-19 had a travel history to mainland China, whereas over 400 out here had a travel history to the United Kingdom. And so COVID-19 in Hong Kong came back from North America and Europe, essentially. What happened was the government in mid-March issued a bulletin. That's the morning news. You can see the coronavirus in the United States. When the US was beginning to be engulfed by coronavirus, the government says that the health authorities have announced that they would like students who are studying in Europe and the United States and North America to return to Hong Kong as soon as possible. That's a hint saying that they're going to start quarantine measures very soon. My daughter was studying in the United Kingdom, and I had to fly there and bring her back. People were coming back. There was a mass influx, and they were wearing masks and personal protective equipment on the plane. And on landing, they had to wear a bracelet, an electronic bracelet, to trace their whereabouts, and they had to stay at home. And while they were at home, they were subjected to COVID-19 screening as well. And they were given containers to provide deep throat saliva for reverse transcriptase PCR screening for COVID-19 before and during their home quarantine period of at least 14 days. And they have to send at least 2 specimens back to health authorities to make sure that they are clear before they can end quarantine in 14 days. And if they break quarantine measures, then the GPS system and the Bluetooth system on their mobile phones would immediately alert the authorities, and then the authorities are allowed to check on you to make sure that you're still staying in the same place. And so if you're self-quarantining at home, then that's a compulsory measure. Why did we not do swabs and did self-expectorated early morning saliva? Because we think that it's sensitive enough, and it's actually safer as well. It's very easily done by people who are very squeamish, and it's actually safe for healthcare workers as well, because what they need to do is basically spit into a bottle rather than performing swabs. And studies in Hong Kong have shown that if done correctly, this saliva has a very good diagnostic yield for COVID-19 and would be an acceptable alternative to performing oropharyngeal and nasopharyngeal swabs, which as a result would be safer for healthcare workers if they do not have to be in the same room or perform any aerosol generating procedures in the collection of these specimens. And of course, if you ask the subjects to cough into a bottle, that would conserve swabs and PPE as well. And that will allow for mass screening to be done as efficiently as possible. So what was done later on, as the outbreak continued in late March, the government had to ban congregations of more than 4 persons in public. And restaurants remained open, but the tables had to be at least 1.5 meters between the two. But bars were closed to stop people from congregating for hours and drinking alcohol. There were curtailed sales of alcohol. Cinemas, karaoke, massage parlors, beauty parlors, gyms, and sports facilities were closed. But there was no lockdown. Everything else was voluntary. And so people were allowed to go to work, people were allowed to go to a restaurant as long as they wore a mask before eating and as long as they followed strict social distancing procedures. And so that's what's happening in society as a whole. But what about the hospital? In the hospital, everybody has to wear a mask. If you're attending clinic or you're being admitted, you have to show documentation. Staff have to show their ID cards at the door. There's security. There are temperature check stations at the door. All visitors have to have their temperatures checked twice before they're allowed in to clinic. And they also have to show their appointment slips as well in order to get into hospital. But if somebody had a recent travel history to anywhere outside Hong Kong within the past 14 days, then they will not be allowed any elective hospital attendances to clinic or any elective procedures. So if you're scheduled to have a cholecystectomy or a colectomy to be done and they found out that you've traveled to mainland China or to anywhere else in Hong Kong within the past 14 days, then the operation will be cancelled. And we're able to check because the hospital computer system is linked up with the immigration department of the Hong Kong government, which has a full history of the travel in and out of Hong Kong. And they can tell you exactly the date in which you have returned to Hong Kong, whether it's the airport or whether it's a railway station. So the hospital will find out even if the patient lies. And there is also very liberal screening for coronavirus for everyone with flu-like respiratory symptoms in hospital, anybody with pneumonia, and all emergency admissions with recent travel, or any contacts or any family members with COVID-19. And because of the high-risk nature of these two subgroups of the population, those from institutional care homes and psychiatric patients, they were also checked as well as they came into hospital. And visits to inpatients were no longer allowed except for compassionate reasons. And there are also strict entry control points, as I've mentioned before. And non-essential and elective attendances at clinics were often rescheduled if they're not urgent. But unfortunately, non-urgent diagnostic imaging appointments, such as CT scans and MRI scans, were also rescheduled as well in order to reduce the strain in the X-ray departments and also to reduce the patient flow inside the hospital. But as a knock-on effect, we also had to curtail our emergency surgical operations. As you can see, the number of COVID-19 cases in Hong Kong was just over 1,000 up till now. But unfortunately, back in February, because of the initial outbreak of COVID-19, people were very worried. And unfortunately, the usual 3-month stockpile of personal protective equipment was actually down to 1 month because the usage rate was 10 times that of the normal. And in order to conserve PPEs, the hospital authority decided that all elective surgical operations had to stop immediately with immediate effect in order to conserve PPEs, because if you intubate somebody, the anesthesiologists and the nurses around the patients have to wear PPE, full PPE, face shield, N95 masks, and goggles and everything. And they consume a lot. So if you're doing a whole day list of 5 cholecystectomies, then that's going to go through a lot of PPE. So that was the reason why PPEs had to be conserved. And that was why elective operations were curtailed. And also, the hospital reserved 1 surgical floor of 2 ORs for emergency cases on confirmed or suspected COVID-19 patients as a contingency measure. And because of curtailment of elective surgical operations, that gave us more liberty in deploying nurses and anesthesiologists to COVID-19 care facilities to concentrate our efforts in that area. But because of the risks and also of the PPEs that are used, elective endoscopies such as colonoscopies were also stopped. But our hospital was one of the few in Hong Kong that continued doing elective and scheduled living donor liver transplantations, because we are the only liver transplant center in Hong Kong. And sometimes these patients could not wait. And some patients undergoing liver transplant have hepatocellular carcinoma as well. And we think that they cannot wait. So they were considered emergencies. And then there were also generalized changes in operating room practices in our hospital. We minimized the number of staff in the OR in order to conserve PPE and in order to reduce the risk of people falling ill if somebody with COVID-19 passes it on to somebody else. And we also tried to minimize the number of staff during induction of general anesthesia and during extubation, because these two episodes for all patients are essentially aerosol generating. And so they want to reduce the number of people affected if there's COVID-19, and we also want to conserve PPEs. And in order to shorten operating times and to reduce the risk of complications requiring reoperation, the most senior surgeon would always perform the operation, assisted by 2 or 1 experienced assistants. And so residents were not allowed to perform any high-risk procedures any longer, even under supervision, because they may take extra time that would take up essential operating slots in emergencies. And if there are complications, then they may need to come in again. So we need to make sure that the quality is always maintained to the highest level. And we also banned all medical students and visitors from entering the operating rooms. This is what happened in mid-April. We actually ended up performing some elective operations. We did not stop all of them, because it ended up that what happened was patients with cancer, patients with organ failure requiring living donor liver transplantation still require surgery. So we had to continue with some services on an elective basis. But what we did was rolling stoppages. So for this week, ending on the 19th of April, we did not operate, apart from emergencies, on Mondays and Tuesdays. And we only operated for 3 days, on Wednesday, Thursday, and Friday that week. And we saved the 6th floor operating rooms, the 2 rooms, for COVID-19. So they were left empty, but always reserved for COVID-19 patients. The following week, we operated on the first 3 days and ended up not operating for the latter half of the week. And that's what we did. So at the end of the day, we did around 50% of our work. We did around 50% of our cancer work. We stopped doing, we chose the patients who needed surgery soonest. So for my HPP practice, we operated on patients who require major hepatectomy because they have very large tumors. There's possibility of major vascular invasion of the tumor. They're in pain, so we did major hepatectomies. We did pancreatic cancers as per waiting list. So we operated on, we did Whipple's and distal pancreatectomies. I did a very big 25 centimeter gastrointestinal stromal tumor that was beginning to obstruct as well. And we performed some laparoscopic surgery. It was not a contraindication per se, but we always chose cancer over everything else. So we stopped doing biliary colics, we stopped doing cholecystectomies as an elective patient. We stopped doing small, benign, or borderline lesions in the pancreas. We made people with small HCCs wait. Colorectal liver metastasis can continue with chemotherapy for a while. Patients with undergoing with neuroendocrine tumors with indolent disease causes had to wait. And all non-urgent CT and MRI scans also had to wait. Emergency services remained unaffected by COVID-19. This is a very nice summary from my microbiology colleague regarding the different samples with positive SARS-CoV on PCR. As you can see here, shedding is seen in the throats, in the upper airways, and in the sputum as well. There's a lot of shedding in stool, but very little shedding in urine and blood and vaginal swabs. So that's a concern if you're operating on somebody, laparoscopically in particular. What about the aerosols? What about the peritoneal fluid? This article, which is very recent from the Annals of Surgery, seemed to suggest that as a case report from Italy, they noticed very large levels, very high levels of coronavirus in the peritoneal fluids in the patient undergoing emergency surgery. So that is a concern. And we decided that we only perform laparoscopic surgery in very selected patients who have had no recent travel history or who have been tested negative for COVID-19 and who have had no known contacts. And we only did them on a case-by-case basis. And we would prefer using balloon ports for 5mm and 10mm to reduce the risk of air leakages during the procedure, and also perform very and use smoke and use filters as well, and very diligent smoke evacuation during laparoscopic surgery. So we continue to perform things like laparoscopic cholecystectomies for emergencies, as well as laparoscopic appendicectomies as well for emergencies, of course. And so far, no one with COVID-19 required any laparoscopic surgery. In fact, no one with COVID-19 confirmed required any surgery in our hospital. We operated on 3 suspected cases of COVID-19 because of their recent travel history, because of the fever and respiratory symptoms, but they were all tested and confirmed to be negative eventually. But we used that special COVID-19 operating room complex for those procedures, and we used them 3 times over the past few months. And also we have, basically, we do not have any other good ideas regarding aerosols. We just have to be very careful and bear that in mind. So laparoscopic surgery was not stopped, but we have to be very careful. And we consider every single case on their merits and risks before we proceed with laparoscopic surgery. And here's the, I'm going to share with you a bit of a complicated workflow as basically the playbook of how we do surgery for suspected or confirmed COVID-19 patients. And this is a detailed protocol or playbook or script that we use and we rehearse for managing patients. F7 is the operating complex where the surgeons get changed. So it's the floor above F6, which is the operating room complex where COVID-19 operations were done. So the surgeons get changed. They wear clean shoes on the 7th floor, and then they wear their dirty shoes on the 6th floor. They change into dirty shoes on the 6th floor, while the nurses prepare everything on the 6th floor operating rooms. The patients come in. On the 6th floor operating rooms. HEPA filters are placed on the corridor. I'm sorry, it's a bit small here. HEPA filters are placed on the corridor to make sure that to reduce the risk of aerosol and viruses on the corridor. And unfortunately, our operating rooms are not negative pressure. So there's always that risk. Unfortunately, our hospital does not have any negative pressure operating rooms. And so we have to be careful and have these temporary HEPA filters on the corridors. And then the patient comes into the operating room and briefing is carried out for the entire team next door. And while the patient is being inducted into anesthesia, everybody non-essential to the induction process gets out of the room, apart from the anesthetist and the nurse assisting him or her. And then the scrub nurse prepares everything outside as well, away from the room during the AGP. And after that, the procedure, the gowning takes place in the room next door. So it's a one-way flow of patients and doctors as well. The surgeons degown in the room next door, and then they change into clean shoes outside the operating theater, and then they go and get changed, and then the surgeons get changed in the usual 7th floor operating room changing rooms. The gowning takes place in the room next to the operating room on the 6th floor. And so there is a clean area where the scrub takes place. There's a clean area where the operation takes place. And then afterwards, there's a dirty area where the degowning takes place. And then it's a one-way workflow. The surgeons do not go back. They do not retrace their footsteps. And that would make sure that if there's any contamination, that's only limited to certain parts of the operating room complex. And then afterwards, the operating room is aired. The whole floor is aired for at least an hour. And then disinfection is done, and then everything goes back to normal again at the end. So that's a detailed playbook, but I think every institution has to have one of these as a contingency plan. And it's important that we have this and rehearse this with everybody around us. What we see here is the different PPE recommendations in our hospital. And so if it's airborne infection isolation, that's for all suspected or confirmed COVID-19 cases, then hand hygiene, N95 masks, gown, goggles or face shield have to be used, and gloves have to be used. Whereas if it's other clinical areas, then the surgical mask is enough. For some intermediate areas where suspected patients are sitting around or in the emergency room, then they have a choice of N95 or surgical masks. And usually people prefer to wear N95 in the surveillance ward because there is always a risk that there are patients who are not yet confirmed but who may be infectious. And for those, eye protection have to be taken up as well. But for other places like clinics, other X-ray departments, consultation rooms, a surgical mask is enough. But we also prefer to wear our own eye protection in clinic as well. So surgical masks are mandatory throughout the hospital, but N95 is only required if there are aerosol generating procedures or isolation wards or the actual infectious confirmed COVID-19 patient areas. These are taken in our intensive care unit. This is a clean area where gowning takes place. We have different sizes of N95s. Depending on the fit test results, different people may use different masks. And it's just pretty standardized issue for everybody. Nothing fancy, but everything's there. But there are strict protocols on their use. You cannot walk around wearing PPE. You wear a PPE, see the patient, and afterwards you go through another room, which is dirty. That's right next to the patient's area, and you degown. As you degown, there's a mirror there to make sure that you're degowning in the right way. And if, for example, if you're wearing a hat, then you have to take it off from the front like that, so that it doesn't go all over you. And you have to make sure that you degown in the right order as well. And everything goes into these red bins, which are incinerated because they are infectious. These are our negative pressure airborne infection isolation rooms in our hospital. And these negative pressure rooms are for isolation of all our COVID-19 patients. So everybody with confirmed COVID-19 goes into these rooms in our hospital. And so the outside door closes before the inside door opens. And if the inside door is open, then the outside door does not open. And that's to make sure that the negative pressure is maintained at all times. And these negative pressure systems are checked every day to make sure that everything's in working order. Just to share a little bit about our medical colleagues' work regarding the treatment for COVID-19, although there is no standardized treatment for COVID-19 apart from supportive care. And apart from the much hyped drug of remdesivir, we have also found that from the previous experiences with SARS, usage of interferon beta-1b plus Kaletra and ribavirin as a cocktail combination together would be better than using Kaletra alone. And that seemed to reduce the length of stay in hospital because it shortened the time in which viral shedding took place. And we found that that was beneficial. These three drugs are old drugs. Interferon's been used for many years. Kaletra's been used for nearly 20 years. Ribavirin's been around for nearly 50 years. They're safe, and we think that these are old drugs for new tricks. This is a recent publication from Lancet, from our hospital and from our university regarding this randomized controlled trial. It's a phase 2 trial. And we would like to bear this in mind. But the most important thing is this treatment has to be started early on, and that means within 7 days of symptom onset or diagnosis. And from our hospital, we always discharge patients under strict criteria. We do not manage COVID-19 at home. All COVID-19 patients have to go into hospital, and you always have to wait 10 days since the onset of illness before they can be discharged from a hospital. And that their clinical conditions must be improving, and they must be afebrile, and they must either have 2 negative specimens taken 24 hours apart, or they have been tested positive for the antibody before they can be discharged. And under these very strict criteria, they can be discharged, but nothing less than that. So in Hong Kong, we have many asymptomatic people who are kept in hospital, and they're complaining, but we think that that is the best way of keeping society safe. This is the situation this morning. We have had so far since late January, 1,052 confirmed cases. Unfortunately, we're no longer at 0 infections now. We had 3 cases yesterday, 3 of which were local infections. 4 deaths so far. But we still think that this is the long haul. It's not over until it's over. While keeping enhanced alertness is till the end, we must never lower our guard regarding epidemic prevention. We are in a prolonged war. I think this sums it all. This is what the president of South Korea said a few days ago. And from here, I think I've been keeping for you for a bit too long, but thank you so much for your hospitality. I came to Brazil and Lucas showed me around, and he also very nice sent me this shirt as well, which I'm so happy that I got, because this is absolutely lovely from him as a present. And thank you so much for listening to me. This is Hong Kong. It's a lovely city. We hope to see you and welcome you when the travel restrictions are lifted. Hong Kong is not all city. There's a lot of countryside as well, and nice beaches. Thank you very much.
Well, Dr. Simon, thank you very much for such a great opportunity for all of our fellow members, colleagues, and students here. We are so glad to hear from you today, your experience in Hong Kong with COVID-19. I am sure that we are all pleased with your presence and presentation. You have a little bit more technology opportunities than we have, and your control of infected people is a little bit better than our control. But it's very interesting for listening how you are doing that. Now I would like to invite Dr. Khalil to share with us his considerations. Dr. Khalil?
Thank you very much, Lucas. Thank you very much for this elegant and clear presentation, Dr. Simon. And you close very well with this beautiful shirt, which of the world champion team in Brazil. So thank you.
Thank you.
I have some questions. First of all, I congratulate your hospital for this very very important considerations. And I'd like to ask you about in the preoperative period, the PCR tests. Are you evaluating all patients in the preoperative period, or only patients going to complex surgeries, or in general elective surgeries too? And in the 48 hours before surgery, or when you use the PCR tests?
At the moment, thank you very much. There's a lot of talk about the routine PCR tests before surgery. But in our hospital, perhaps we're very lucky in that relatively few people were affected by COVID-19 in Hong Kong at the moment. And we do not actually perform any routine PCR tests before elective surgery. We only perform PCR tests for emergency surgery patients. For example, who have respiratory symptoms, who have had pneumonia, influenza-like illnesses, fever which cannot be explained, some changes on their CT scan thorax, or who have returned from abroad and who have not waited for at least 14 days. But we do not perform routine PCR tests on all other elective cancer patients. What we do is we take a detailed travel history, contact history, and make sure that the temperature is okay, and make sure that they're not lying, and then we would usually perform surgery on them. So I think that if the outbreak gets worse in Hong Kong, we will have to do routine PCR testing, because I think there are some places in the world where nearly half the patients who undergo elective surgery are COVID-19. I think that this is very important. But at the moment, we do not perform routine. But I think that it depends on the testing capabilities as well. We have testing capabilities, but they're limited. They're very widespread in the community. But for hospitals, we usually just select out the patients whom we test.
Okay.
Rather than doing a blanket test for everybody.
Okay. We started testing our patients a few weeks ago, 48 hours before.
I think that's a very good idea.
Surgeries.
Yes. I think that's a very good idea, because I think that if you have somebody coming in, it places additional risk to everybody. And the last thing we want is a hospital outbreak of this coronavirus, because I'm not sure about the situation in Brazil, but what we saw in Hong Kong in 2003 in SARS was really painful, when the first outbreaks were actually within hospitals, and the community outbreaks came out of the hospitals. They were discharged home, and then there were community outbreaks. Whereas in Hong Kong now, it's the opposite. It's the community outbreaks, small-scale community outbreaks. But we managed to contain the community outbreaks before they enter hospital. But I think that if the community outbreak gets worse, then we will have to do something in the hospital, like widespread screening. But what's the turnaround time for testing in your institutions? Is it like a few hours, or 1 day or 2 days before, if you need to do that routinely?
2 days before. 2 days,
2 days
before.
Yeah.
Real.
Mm-hmm.
Another question is about you told us about that you use a single floor surgery theater room for COVID.
Yes.
We don't have this possibility in all hospitals, especially here in Brazil. Fortunately, we have 9 hospitals in our complex, and one of this is only for COVID. So we have a theater room specific for surgeries for COVID.
Yes.
But I think a lot of hospitals here in our country don't have a single surgery ward to perform surgeries for COVID. So of course don't have 2 negative pressure systems. It's not so frequent to have negative pressure systems in our country. So what is the limit of this to return the surgical production if we don't have a surgical theater room specifically for COVID? What is your opinion? What do you think about this?
I think if one does not have a dedicated surgery complex for COVID-19, then I think the most important thing, I spoke to the operating room nurses yesterday, and the priority is actually to limit the traffic in and out of the room. And so I think that if you do not have for example, for us, for COVID-19 patients, they only go one way. So they come in one side of the room and they go out the other side. And all the staff as well, they come in one side and they go out the other side. we have back staircases to the changing areas. And so we probably need to think
a kind of physical barrier.
Yes, we have some kind of physical barrier. And I think perhaps if you do not have a dedicated area, you could put up screens, and then you can have HEPA filters along the way. They are portable HEPA filters that have wheels. You put them around you, and then one probably has to seal off the complex when the COVID-19 patient comes in. And you have to limit the travel, and you have to limit all staff to make sure that nobody comes in who is not actually involved in the care of that patient. And then they have to go out the different door as well. So it's very disruptive in a way. But I think that if there is no physical floor, then barriers would do. But I think a lot of attention has to be made on disinfection. For example, all the surfaces are covered in plastic bags. So for example, the phones, computer keyboards, screens, anesthetic machines are all wrapped up in transparent plastic inside the COVID-19. So afterwards, they are cleaned, or the plastic's thrown away, and the room's disinfected. It's very disruptive, but I think that the most important thing is if there is no dedicated complex, then you could try to limit the traffic and to have a dedicated one-way flow system. One side's clean and the other side's dirty. And then if that's possible, then I think that that can be done. But I must admit that would be quite disruptive. We have 6 floors in our operating rooms, and we left 1 floor for COVID-19. So we were lucky in the way, but that floor only has 2 operating rooms. So the other floors were relatively unaffected. But I think that the most important thing is to limit the traffic.
I observed that you are performing a number of laparoscopic surgery, and there are some recommendation to choose open surgery instead of laparoscopy. There are some reason to choose surgery instead of laparoscopic surgery.
Yes, yeah, very good reason as well, because you worry about aerosols from the peritoneal cavity. You're worried about the suction and the smoke being inhaled by everybody around, and that the laparoscopic surgery may actually spread it all over the place. I think that this is a very genuine concern. We have done much less laparoscopic surgery now compared to before, because what we're doing now is, for example, in HPP, we've stopped doing gallbladders as elective cases. But for colectomies, our colleagues are doing less as well because they're doing more advanced cancers. And we choose to do the more advanced ones electively. And so we ended up doing much less laparoscopic surgery. But for things like laparoscopic appendicectomies, we believe that for the moment, the demographics in Hong Kong show that since COVID-19 is still not very prevalent in Hong Kong, that we still have luxury to do laparoscopic surgery in very selected cases, whom we could deem to be safe. But I think that there are also guidelines issued by the American College of Surgeons and also elsewhere, including the United Kingdom, where they say that laparoscopic surgery is certainly high risk. I think that this has to be reviewed all the time, given the additional concerns regarding the presence of high viral load in the peritoneal fluids. I think this is a genuine concern. That I think this is one thing that we haven't paid enough attention to, in which we probably have to change at some point.
Do you use a specific filtration system in the moment of deflation of the pneumoperitoneum?
We just use no, we don't. We use the usual filters when we deflate, and we put the we also make sure that we suck everything out through the filtration system before getting during deflation. But what we do is probably not much different from our usual practice. But we've been doing very little laparoscopic HPP surgery recently, I must admit.
Okay. It's interesting that you are continuing your living liver transplantation program.
Mm-hmm.
Yeah. We stopped here our living related program and kidney too. and lung transplantation too. We are performing very specific, in very specific situations, the indications, the transplant, and only kidney transplants are doing frequently. We perform more than 20 in this month, but living related we stopped. But I know that the cadaveric donors is very, you don't use cadaveric donors in your country, yes?
We do. We've done quite a few.
Oh yeah.
I think, yeah, we've done quite a few. I think we've done nearly 20 since the beginning of the year. We don't have that many cadaveric donors compared to Brazil or other countries in Europe or North America, but we have not stopped doing cadaveric liver transplants in Hong Kong.
We are a little bit afraid to perform in liver-related transplants, but okay.
Yeah, yeah, because I don't think that's based. Our decision was not based on any particular evidence apart from the urgency of the transplant. We always have people working up for living donor liver transplants, and luckily we got a green light from the hospital chief executive, who has the ultimate say on what operations can proceed and what has to be stopped. And our chief executive has been very supportive of our living donor liver transplant program. So we're continuing with that during this outbreak. But we have to frequently review what's going on. And if things get worse, then we probably have to curtail them. But I think the whole situation is very dynamic and fluid.
Okay, Lucas, I think we can listen others about the presentation of Professor Simon.
Yeah, I don't know if we have any questions from the audience.
Lucas, is Jorge Lira. Okay.
You can talk.
So, Professor Simon, my name is Jorge. I'm also maybe from BSSO. And I live in a middle-sized town in the northeast of Brazil. And here it's very difficult to us to perform PCR tests in our patients. And the incidence of COVID-19 here it's very high. So now we are seeing cases in our hospital that patients, cancer patients, for example, pancreas cancer, that they had COVID-19. They have the symptoms. Now we want to perform, but we don't have the capability to perform the PCR tests.
Yeah.
So how long do you think we should take to perform high complex surgery, like, for example, a Whipple procedure in that suspected COVID-19 cases?
I think, yes, we have not operated on, we haven't done any Whipples on any suspected cases. But if testing is difficult, I would recommend that one would you be able to do, for example, a CT scan of the thorax, just a plain CT of the thorax, to see if there are any possible changes? Because I think CT scan is also quite sensitive, even in early phases of the infection, if it affecting the lungs. But I think to be safe, if the patient has any symptoms, they should not be operated for probably at least 2 weeks. And if they have pneumonia, then that pneumonia has to be treated as well, because we're worried about superimposed bacterial pneumonia as well. So we would give them antibiotics and treat them empirically, even if COVID-19 PCR is not performed. If they are clinically better, for say 2 weeks later, and if they have a CT thorax, which does not show any pneumonia after 2 weeks, perhaps, this is my opinion, only my opinion, I think that some people in mainland China use CT thorax rather than PCR, because CT thorax can actually be quicker. So I think perhaps if you're worried that the cancer may catch up on the patient and if you do not operate early enough, then if the patient shows clinical improvement, if they're febrile, if they're feeling very well, then if you do a CT thorax 2 weeks later and they are clear, then that may be considered. But I would be very careful because some patients may still be shedding the virus even when they're feeling very well. There are these asymptomatic patients or with very, very minor symptoms like sore throats that may place everybody else in additional risk. It's not to the patient themselves, but I think it's to the surgeons, to the nurses, to the people in the hospital as well. So I think one has to be very careful. If you have antibody tests, that may be helpful, but I think you have to tread very carefully. For example, with many of our colorectal cancer patients with colorectal liver metastasis, we tend to, if they are asymptomatic, we tend to give them chemotherapy for the time being and wait. I think that if you have facilities for chemotherapy, then that may be helpful as well. Although this is, of course, not evidence-based, but this is probably what I would do if there are situations that limit your usual practice. But yeah, I think a CT thorax may be helpful.
Yeah, we are doing something like that. We are, because we have so many cases of COVID-19 here. So we are trying to perform surgeries only in patients without any symptoms, even minor symptoms like sore throats. And like we are taking 2 weeks, sometimes more. But the problem that we don't have PCR here, and even when we have, it takes like 5 to 7 days to have the results here. So it's hard for us. And I think Brazil is a big country. I think some people here probably here in the web conference, they probably are like we are facing here.
I think in China, when the outbreak first started, there were problems with testing as well. But I think in order to ramp up testing, before the testing was ramped up, CT thorax was very widely done. And I think that may be one option. But I think one has to tread very carefully because we are beginning to experience patients with prolonged waits for surgery, and they are suffering. So this is a collateral damage. I think testing should be done for if there's a widespread population prevalence of this infection. But if testing cannot be done, then there are other surrogate measures like a CT thorax may be helpful. And I think very good history taking is irreplaceable. It's the best thing that's around. And good protocols as well. But I think it's a difficult situation for all of us.
Thank you.
Thank you. I think we are late now. Yes. It was a great event and opportunity for information sharing and learning opportunity. We are very thankful for you, Dr. Simon, on behalf of the Brazilian Society. On behalf of the Brazilian Society of Surgical Oncology and its regional chapter, Rio Grande do Sul, I would like to thank you very much, our audience, Dr. Khalil, Dr. Jorge Lira, and a very special thank you for you, Dr. Simon, that kindly joined us from Hong Kong. Thank you very much. Just remembering the presentation will be available at sbco.org.br. I think we can finish now.
Thank you. Thank you. Okay, bye. Thank you, Simon.
Thank you very much.
Thank you very much.
Thank you.
Thank you. Stay in touch.
Yeah.
Bye.
Stay healthy.